Looking at your APGAR score in more detail, I see that, it looks like 3 or more times for the activity changes, the daytime symptoms, the nighttime symptoms. And down here, I do notice that it says you're using your rescue inhaler several times a week. In fact, sometimes even several times a day. But this is not where we'd like it to be.
So my lungs aren't working well?
No, they're really not working like we'd like them to, and this is due to your asthma. And I think that actually you probably have severe asthma when we take into account.
Severe asthma? What does that even mean? Oh, I'm probably going to need to have another inhaler. I wonder if this means that my asthma is getting worse.
We normally think of asthma as being divided into severe asthma, non-severe asthma, or persistent asthma and non-persistent asthma, or controlled or non-controlled asthma. And it's important to sort of recognize asthma in its manifestations and how to differentiate between those different subgroups. So IgE is an antibody that binds to mast cells, and on the other end of the antibody, it binds to different allergens, and it's quite upstream in the pathophysiology of asthma. What happens is the IgE binds to allergens when it's bound to the mast cell, and when it cross-links with another IgE bound to the allergen on the mast cell, it causes the mast cell to degranulate and release its mediators, things like histamines and leukotrienes and platelet activating factor, and that causes some of the inflammation and some of the recruitment of the other cells, including eosinophils, that releases its own mediators. And so it's a very complicated mechanism, but it's important to recognize that all of these features can be at play in different patients. Now we're honing in even more beyond just phenotypic recognition, but what's causing those specific phenotypes. And we refer to those as endotypes. And those are specific patient characteristics based on the underlying mechanism. So we're calling patients, okay, you have eosinophilic asthma, you have neutrophilic asthma, you have IL-5 mediated asthma, you have IgE mediated asthma. Those are examples of specific endotypes that characterize the underlying inflammatory pathway in a given patient.
Well, and certainly the ACT and the ATTACK and the ACQ have all been around for a long time. The asthma APGAR is relatively new. Well, then obviously I have a bias having worked on the asthma APGAR, and the thing that it does that ATTACK and ACT and ACQ don't do, it goes on and asks about triggers, it asks about adherence, and is linked to an algorithm for care.
But over the last year or two, we've developed other therapies that target specific pathways, that target specific entities within the asthma pathophysiology spectrum. And so, for instance, novel therapies that have been approved by the FDA include the anti-interleukin 5s. And so by giving anti-IL-5, we can prevent eosinophilic inflammation from ensuing.
But there's also fear. I think sometimes we need to understand patients' feelings and patients' preferences. And how do you incorporate patient preferences in your choices?
I think it's important to recognize that there are choices. That's the first thing. And so we need to offer our patients what suits them best. Some patients prefer taking a pill. Some patients prefer taking an inhaler. Some patients, don't want to have a shot, and they might prefer a procedure like bronchial thermoplasty.
What do you think is really critical to be in an asthma action plan?
So I think the first thing is recognizing the frequency of symptoms. How often is rescue medication inhaler being used? Those are important things just for the patient to recognize when asthma is so severe that it needs to be acted upon urgently.
Well, and sometimes it's a matter of almost giving the patient permission because, oh, I don't want to call the doctor's office and bother them. I certainly don't want to call 911 unless I have to. So the asthma action plan gives them the specifics and the permission